Hello friends, today I'm going to discuss here about MCQs for MRCP Part 1 exam, Psychiatry MCQs. Okay, let's begin. A 46-year-old woman has a GCS score of 10 is to 15. Ambulance staff report that they found several empty diazepam packets on her kitchen table, prescribed by her GP due to difficulty in sleeping triggered by difficult marital breakdown, which is the single most appropriate medication to administer initially. So, guys, let's see what is the case here. This is diazepam toxicity. So, diazepam toxicity is a benzodiazepine toxicity. What is antidote? So you have to answer. Let's discuss everything. Adrenaline used in some emergency situation, okay, like cardiac arrest, and flumazenil is answer here. This is antidote of diazepam or benzodiazepines, whereas an acetylcysteine is used as an antidote in case of paracetamol toxicity. Naloxone and naltrexone is an antidote of opioids. So guys, if you know answer in this manner, that means you are able to score excellent rank in exam. Let's see here discussion about flumazenil is a gamma aminobutyric acid GABA antagonist available for injection only, which can be used as an antidote in the treatment of benzodiazepine overdoses. Long-acting benzodiazepines such as diazepam may require repeated administration of flumazenil due to its short half-life. Diazepam is a benzodiazepine medication commonly used for short-term relief of anxiety and sleeping problems, whereas adrenaline has various uses of emergency medicine, but reversal of benzodiazepine overdose is not one of them. Remember, many generic drug names have been changed following the international non-proprietary name rules. However, the adrenaline, epinephrine, noradrenaline will continue to be called by both names because it is believed to be too risky given their widespread use in emergency medicine, and acetylcysteine used in management of paracetamol overdose. We already discussed naloxone is opioid inverse agonist drug used to counter the effect of opiate overdose, whereas naltrexone is an opioid receptor antagonist, usually primarily management of alcohol dependence and opioid dependence. Naltrexone we can use in both in alcohol dependence or in case of opioid dependence. So guys, naltrexone is Naltima. The medicine is Naltima. Now, 73-year-old man has Alzheimer's dementia with MMSE2 of 24/30. He lives with his wife. Although is largely independent, having only recently retired from teaching, he has never been lost or disoriented whilst away from the home. He asked for advice about the driving as his wife never learned and relies on him, which is the single most appropriate advice to give. He should arrange to undergo driving assessment test. He should inform the DVLA and his insurance company. He should inform the DVLA, who will retract his license until he passes an assessment. He should stop driving immediately. His doctor should inform the DVLA on his behalf. So which one is the best answer here? So what is single best answer? So guys, this is very simple. He should inform the DVLA and his insurance company. Why? Once informed, the DVLA would then ask for consent of to contact his GP or a specialist for medical information, and based on this may ask him to undertake driving assessment. Then he may be issued for license for shorter period and need regular assessment. So guys, this option is very clear. Such MCQs are not repeat every time. Let's discuss. A 29-year-old man has had a spasm in the neck and rolling off his tongue. So neck spasm, rolling off his tongue for the last day. He started taking haloperidol 10 mg once daily 1 week ago, which is single most appropriate description common side effect. So what is this? Patient has neck spasm, rolling of his tongue. Okay, for the last day he started on haloperidol like antipsychotic. So guys, what is this? This is an acute dystonia, akathisia, tardive dyskinesia, tics, or Parkinsonism. So guys, this is not a Parkinsonism. Why? Because here is history of haloperidol intake. Tics, this is absolutely not a tick. This is not a tics. So this is a case of acute dystonia. Let's see the explanation. Acute dystonia is a reaction following exposure to antipsychotic medication with sustained, often painful muscular spasm. Remember, muscular spasm is painful. More frequent are neck dystonias. Remember, neck dystonias are more frequent, followed by tongue and jaw. Incidence is 3 to 10% patient exposed to antipsychotics. Up to 30% with high potency drug, younger age group males and high potency antipsychotic confer higher risk. 90% of the onset symptoms occurs within the first 5 days of exposure. Akathisia is a subjective feeling of inner restlessness and objective psychomotor agitation such as pacing associated with antipsychotic medication. Tardive dyskinesia is involuntary, repetitive, purposeless movement occurring with long-term antipsychotic exposure of month to year. Tic is a sudden, repetitive, non-rhythmic motor movement or vocalization involving discrete muscle group. Tics are not a common side effect of antipsychotic medication. Parkinsonism is a frequent adverse effect around 20% of patients treated with antipsychotic medication. Parkinson's disease is a progressive neurological condition not associated with antipsychotic medicine per se. So hope till here it's clear. Now, next MCQ. An 18-year-old man is admitted to the psychiatric ward. For the last 2 weeks, he has felt people were following him. Has overheard stranger talking about him. He has ideas of reference, vivid auditory hallucination, social withdrawal, unusual behavior over the last year. And that he has recently dropped out of college. He reports smoking joints almost daily for the last 12 months. What is single most appropriate diagnosis? He reports smoking joints almost daily. What is this case? Acute schizophrenia like psychotic disorder, mental with behavior disorder of cannabis, amnestic state, mental and behavior disorder of cannabis, psychotic schizophrenia like, mental behavioral disorder due to cannabis withdrawal with delirium, paranoid schizophrenia. So guys, this is very simple. He reports to smoking means cannabis, some psychotic symptoms are there and schizophrenia like. So this is a case of C option. Now let's discuss why so. Mental and behavioral disorder due to cannabis, psychotic disorder, schizophrenia like drug-induced psychosis are characterized by a cluster of psychotic phenomena that occurs during or immediately after psychoactive substance use and are characterized by vivid hallucination. Auditory, but often in more than one sensory modality, ideas of reference, often paranoid and persecutory nature. Psychomotor disturbances and other psychosis-like symptoms. The sensorium is usually clear, but some degree of clouding of consciousness may be present. While on ward, he should ideally have no access to illicit drug. Confirmed by repeat urinary testing, and symptoms should resolve at least partially within 1 month and fully within 6 months. Particular care should be taken to avoid diagnosis. A more serious condition like psychotic disorder should not be made merely on the basis of perceptual aversion, hallucinatory experience. When substance having primary hallucinogenic effects like LSD, mescaline, cannabis at high doses have been taken. In acute schizophrenia like psychotic disorder, the psychotic symptoms are comparatively stable and justify a diagnosis of schizophrenia, but have lasted for less than about 1 month. So guys, I hope the explanation is clear now. 30-year-old woman comes to the emergency department with palpitation. Remember, 30-year woman present with palpitation in emergency department. That is associated with tension headache. Her ECG is normal. A full history reveals that she has been worrying almost daily for several months for no apparent reason. Without any reason she is worrying, with no subjective precipitators. She feels constantly nervous and jumpy, She has no other symptom. What is the single most likely diagnosis here? Acute stress disorder. This is not acute stress, we can say. Generalized anxiety, panic disorder, pheochromocytomas, thyrotoxicosis. Guys, this is not pheochromocytoma because no laboratory investigations are there. This is not a thyrotoxicosis. Panic disorder, not really look like panic disorder. This is generalized anxiety disorder because almost every day worrying without any reason. Let's discuss what is generalized anxiety. The most likely diagnosis is generalized anxiety disorder. This has been described by the NICE as a very common but under-recognized condition, characterized by endless worrying, which result in substantial disability for many sufferers, affecting their capacity to work and their life fulfilled and meaningful lives. Its symptoms are hard to define as they are never constant free floating. Anxiety about everything, with some symptoms, somatic symptoms, but with no clear causative or alleviative, actually managing symptom worries. There is often an acute or chronic element to the disorder, with symptoms changing over time to have more or less effect on activities of daily living. Acute stress disorder would arise following a significant trauma. Without this event, it would be unlikely in both agitations. The overlap of symptoms with generalized anxiety disorder, arousal, tachycardia, sweating, etc. So guys, overall, this is a generalized anxiety. Hope it's clear. If you like this video, put like on it. If somebody is new on my channel, please subscribe this channel. So I bring a series here for MCQs of MRCP 1 to 5 for psychiatry, then 6 to 10, 11 to 15. Such MCQs I am going to bring all subject wise for MRCP. Thank you.